Okay. All right, so for those of you who don't know me, I'm Brian Harder, and tonight we're going to be talking about diagnosis and treatment of multiple canal benign paroxysmal positional vertigo. So this case is from my fourth rotation, which was done at Rehab Associates of Central Virginia, and it was a specialty vestibular rotation. And before we get started, here's some quick background information about the case. So every year, 5.6 million patients seek medical help for dizziness, and benign paroxysmal positional vertigo, or BPPV for short, is a common cause of dizziness. This is due to loose otoconia or calcium carbonate coming from the utricle that floats into the semicircular canals. Evidence shows that cannula repositioning procedures are more effective than any other treatment, whether it's medication or rest, in returning the patient to normal function. The purpose of the case that I'm presenting is to discuss how a patient with multiple canal BPPV can present and a series of treatments performed to help the patient return to normal function in a short period of time. So this patient was referred to us by his primary care provider, and the initial eval was done on February 2nd, 2017. He's a 60-year-old male bus driver, and his chief symptom that he reported was dizziness. He'd been having episodic symptoms since 2002, so on and off with bouts of dizziness for about 15 years. He had a recent increase in symptoms in January 2017, and at the end of January, he went to the emergency room at Lynchburg General Hospital and was kept overnight for chest pain, dizziness, and numbness on the left side. It was diagnosed as a possible TIA, and while he was kept there overnight, they ran an MRI of the brain, which was given as clear. He had a hearing test done in December for his job as a bus driver, so for his CDL license, they have to do a hearing test. And they showed no hearing loss at that time. After being released from the hospital, he had a cardiology consult because his blood pressure was elevated when he was in the emergency room. And they said that they could find no cardiology impairments and gave him no answers at the time. So by the time he got to us, he was pretty frustrated and he just wanted someone to tell him what was going on. He also had scheduled after our initial eval, an eval with a neurology and ear, nose, throat doctor. So when he presented to the clinic, he had dizziness accompanied by imbalance, ringing and fullness in the ears, and also having a fluttering or fluid moving feeling in the back of his head. He related the ringing and fullness in his ears to he got impacted wax pretty much yearly, and so he said that it felt the same way, and that's what he described as that ringing or fullness feeling. It felt exactly the same as that. He said that he had no motion sensitivity or claustrophobia at baseline. And the reason I ask about those is because we want to make sure when we get the frontal goggles on that we're not going to increase his anxiety and have other symptoms as well due to that. Never been diagnosed with migraines, and he reported that he had never had any specific head or neck trauma. He said that he had stood up into like the bar at the top of the bus a couple times, but he never even saw stars when he had done that. He also reported that he had never received treatment before for vertigo and had never been diagnosed with any vestibular dysfunction. He also reported that he only sleeps on his back, and he was adamant about this, and because I asked it a couple times, because a lot of times sleep positioning is important as too in regards to vertigo. If he's rolling back and forth a lot at night or tossing and turning, we want to know exactly what position he's most comfortable sleeping in. As for pain, the questions I asked were about his neck, headache, and dizziness. And as you can see here, scored from 0 to 10, 0 being no pain, and 10 being the worst or the highest severity. So for his cervical spine, he had a lot of discomfort and stiffness, which was currently a 4 out of 10, and the highest was a 6 out of 10. For headache, and we'll go further into his headache later on as well, but sitting here in the clinic, he had no headache at the time, but at the worst, it was up to a 4 out of 10. And for dizziness, sitting in the clinic as well, it was 0 out of 10, but at the worst, it got all the way up to a 9 out of 10. The following limitations with activities and participation were for his current status, not just his most severe that he had ever experienced. So currently the patient was having difficulty going grocery shopping, looking up and down the aisles, looking at stuff on the shelf, so a lot of head turns, which also made sense why he was also having difficulty bending over, looking up, and also going up and down stairs. He reported that he had no limitation due to dizziness with watching TV, reading, driving, getting out of bed, or walking. The reason driving is asterisk is even though he said he had no dizziness, he had not been working as a bus driver since he was in the emergency room a few weeks prior. And but he did report that he was just not feeling right, and that's why he didn't want to work. So that's where just kind of digging in through So even though he didn't say specifically about dizziness, something just wasn't right for him. Overall, his perceived function was he rated himself at 70%, that he could do 70% of the activities that he wanted to do without dizziness. As for a quick review of his medical history, he said that he had no recent surgeries. He did have hemorrhoid surgery about 5 years ago. And he and his wife both said that for the last 2 years he's been having some short-term memory issues. Said that they couldn't relate it to any correlation with increased dizziness or anything like that either, and that it's been kind of fluctuating here and there as he went along. He also reported having this lightning bolt or ice pick headache. As we learned in differential diagnosis class as well, a headache like this could be a sign of a blood clot or an aneurysm, so we continued to ask him about it every time that he came back into the clinic. The last time that he had a headache like that, though, had been prior to his stay in the emergency room, so it wasn't on the top of my ladder of stuff that I was looking at the time. As for medications, he had been prescribed atenolol when he was in the emergency room due to that elevated blood pressure, and he had been taking it consistently since then. As for going into the physical exam then, I started with a cervical screen, and the patient presented with no limitations with cervical extension. He was able to get full 45 degrees of extension. He did show limitations with rotation both to the right and to the left, 68 degrees to the right and 70 degrees to the left, and had increased muscle tension throughout bilateral trapezius, greater scapula, and suboccipitals. As for the ocular motor exam, I did do a smooth pursuit test with him, or H test, and he did have saccades with the horizontal component. As for convergence, that was negative. He had no double vision with the finger within 4 inches of his nose. And for 2-point tracking, he did have a slight overshoot. Now, a slight overshoot could be slightly indicative of a central sign, but at this point in time, just because it was so slight as well, didn't pursue it at this point, decided to go into the vestibular testing instead and see what happened at that point. So for the vestibular testing at this clinic, we use Frenzel goggles, which have a camera in them as well, so that way we can see an enlarged view of the eye. So for these 3 parts of the test, we use the goggles. So for the first one is spontaneous nystagmus, and for that we looked with one shutter open on the goggles where he can fixate his eye on the screen, and he did have a left beating nystagmus with fixation, which reversed to a right beat when we closed the shutter up. And he was at, this is an abnormal finding though too. Usually you're going to see same nystagmus both with fixation and without fixation. So we don't know if that was just an error with a little bit of the reading as well. From there we went into a Dix-Hallpike test, and the first one I did was a right Dix-Hallpike, and he had both a right beat and an up beat that lasted roughly 45 seconds. For this entire test, he had dizziness throughout the entire test from the moment I laid him down until he sat back up. I did not get a severity scale like I did for the left beat, as you can see below, but he did report that dizziness, and he did have that up beat as well. As for the left Dix-Hallpike, he only had a left beating nystagmus, and the dizziness only started 20 seconds into the test with a severity of 3 to 4 out of 10. From there, I let all of his symptoms calm down, and then I did a roll test as well. For the right roll test, he had a right beating nystagmus or geotrophic nystagmus, and then for the left side, he also had a left beat or also a geotrophic nystagmus. With the right side having it was a quicker, fast beating component. So I wasn't able to get a video of my patient's eyes, but this is a quick example of what we're watching for with using the frontal goggles. So the first part of this test, that quick movement, that's what, as you're laying the patient back down. And then once he was down, you can see how the eye started bouncing up. That's your upbeating torsional component. And then after about 15 seconds or so, it's going to calm down and have more of a horizontal component as well, because this patient also has a geotrophic and torsional nystagmus. So you'll be able to see it start beating more towards the right side of the screen. And at our clinic, we didn't have the 2 eyes like that. We only had the one, so it looked way less creepy than the 2 eyes like that. All right, so for outcome measures, rehab associates, they always use photo with all their patients that come through the door, or focus on therapeutic outcomes. So his intake score was a 45%, and for this outcome measure, it compares. It's done on a tablet, when the patient arrives and compares the patient to over 9 million other patients that are also in the system. And it kind of categorizes them based off their symptoms. So with that being said, that's why he had the 45% score based off those, and they are also able to predict the discharge score for him, which was 69% in 9 visits. He had a dizziness handicap inventory score of 40 out of 100. The higher the score, the more severe the symptoms, and a 40 out of 100 is a moderate handicap. For the dynamic gait index, you can see the score is 9 out of 12. Usually the full score is out of 24, but I only performed the first 4 items. The first 4 are more indicative for vestibular testing. The other 4 are just good for more general dynamic testing, and just for the length of time that it takes to do them all. That's why I only did the first 4 as well. So for evaluation, the patient would benefit from vestibular PT for Canal repositioning, adaptation, and habituation to assist with balance and training. Patient and wife were involved in the development of the plan of care and gave consent to treat. Also in our electronic medical record, I did select a couple other drop-down options, which were prevention for loss of balance and falling, and impaired peripheral nerve integrity and muscle performance associated with peripheral nerve injury. With all that being said, the diagnosis that I arrived at was multiple canal benign paroxysmal positional vertigo of the right posterior canal and horizontal canal diastasis. The prognosis for his dizziness for this is good, just because we can do the specific BPPV treatment. As far as his other impairments, though, it was uncertain based off that headache that he was reporting. As far as BPP, the exercises go and treatment, it's not necessarily going to address a headache, but some patients do report increased or better symptoms with that as well. As for plan of care, photo recommended seeing the patient for 9 visits over 5 weeks. Our clinic setup was only scheduled the patient 1 visit out at a time because we went off of their subjective report of no feeling 100% and also having no positive Canal test. So doing the Dix-Hallpike interval test and having no positive results. Here's a quick, the ICF model. So we've already covered all these parts individually before. So the health condition, impairments, activity, participation, his environment. I mean, obviously at home, outside work, different types of vehicles, especially as a bus driver. And his personal factors, he was very frustrated when he arrived. His anxiety level was high. I mean, he's seen so many doctors already, been in and out of different clinics. He just wanted answers, and he said he'll do whatever it takes just to return to his prior level of function before the dizziness came on. For those of you who had neuro class, this is from that class, and it's just a quick overview again, and it was very helpful in the clinic to have it too. Just for ruling out different differential diagnosis. So we know he has a history of vertigo before, and it lasts seconds to minutes. So that helped guide us over to his vertigo positional on the left-hand side. And obviously then I did the Dix-Hallpike and orbital test. So I did both of them, and the conclusion was the diagnosis of BPPV. At this point, any questions? All right. Yes?
Was he a self-referral or was he a PCP?
He was referred by his PCP, and she was a nurse practitioner who had worked with us a couple times before. Yes. So for the course of interventions that we performed then over the next couple visits, every treatment was the same basic format, and obviously, depending on what we saw, it would change from time to time. But we always started with canal testing, making sure that the canals are clear before going into any other treatment. If there were crystals out in the canal, I would do a CRT or a Canal repositioning treatment as needed, and then from there would progress into different vestibular rehabilitation exercises. So at his initial eval, I wasn't just going to make him dizzy and not try to treat him at the same time. So I did the Canal repositioning treatment. Started with the right epaulet for that right posterior canal. Waited about 5 to 10 minutes for everything to settle down, let his dizziness drop again as well, and then went into the left appiani for the horizontal canal. After that, I instructed him on 24-hour postural restrictions. And for rehab associates, this consisted of just no bending over, looking up, or turning your head quickly up and down, side to side for the next 24 hours, in addition to that night sleeping on your back with 2 pillows underneath your head. Reason being, it just helps put the canals in the best possible position for not a lot of movement. I also did a cervical treatment for him, and so I did that consisted of heat and electrical stimulation, and that was after the Canal repositioning treatment for the Easton I used pre-mod. The manual therapy then was to reduce cervical tension, and emphasis was on his suboccipitals, and I did a suboccipital release at the end. I also gave him a home exercise program, a cervical retraction exercise with chin tucks, just to get something started to keep the muscles a little bit looser as well. At his second treatment, he came back in saying that he felt 50% better since his initial eval, so we've already made some improvement, but the dizziness did come back over the weekend, just not as bad. So after doing the Canal testing, saw that the horizontal canal was still involved. Posterior canal looked good at that point, but still some reversal with the roll test. So did a left appiani. From there, went into heat, E-stim, and manual therapy for cervical again. And then at the end of his treatment session, taught him how to perform the left appiani at home. So I performed a demonstration myself for him, and then also gave him a handout so that he knew how to do it at home as needed. We didn't give it to him to do every single day or anything like that. It was just if his dizziness got over severity of 5 out of 10, to perform it at that point. From there, he was scheduled for his next treatment 2 to 3 days later, and he felt 80% better when he came back that time. He did have some dizziness still with driving though. So I did the Canal testing, which was negative, and then performed heat, E-stim, and manual therapy. After that, I went into the VOR, or for his vestibular rehabilitation. So started with VOR ×1, which is keeping the arm still and turning your head back and forth, keeping your eyes fixated on a single object. And he was able to pass the 4 levels that we assigned at the clinic, which were sitting, standing with a busy background, and then walking as well. He had no dizziness with any of those. So then I moved into VOR ×2. So moving his arm in the opposite direction of his head back and forth for 1 minute, and did those 4 levels as well. So in the clinic, he was able to pass level 1, and level 2 gave him some difficulty, which was standing with a blank wall behind it. And so that was given to him as a home exercise program, advancing into levels 3 and 4 as he felt able to with no symptoms. Treatment 4 was also his discharge, because when he came back, he was reporting feeling 99% better. He completed all the way through VOR ×2, level 4 with absolutely no symptoms. Canal testing was also negative, so it was a quick treatment and just reviewed his self-management of symptoms if they were to return, how to use the VOR for self-management, and also how to do the left appiani if needed. So we've already discussed going through already the home exercise program that I did, the 24-hour precautions and cervical exercise initially, followed by the left appiani and the VOR. His response to the treatments were for pain, he had no pain with any part of his cervical spine. He reported no headaches or dizziness since his last appointment. As for functional status, he said he had been grocery shopping, able to bend over, look up without any problems. He'd been driving, back at work, working a full 40-hour work week, and had no dizziness any part throughout his day. So he did give a perceived function though, still at 99%, because he was still a little leery of it coming back in the future. So he wanted to kind of keep that 1% for himself. As for photo, when we redid it, his final score was a 97% in 4 visits, even though he was expected to only get to 69% in 9 visits. His DHI dropped from 40 out of 100 to a 0, and his DGI went from a 9 out of 12 to 12 out of 12. Cervical rotation didn't change that much. We didn't do very many exercises or anything with him either, just a little bit of heat and E-stim, so that didn't really surprise me with those results either. As for the Canal testing, you can see he still had a right beating nystagmus in all tests. The fact that it's all in the same direction shows still a slight hypofunction, but there was no signs of BPPD at this time. As for modification of treatment, he was a straightforward patient in the regards that we didn't have to do anything outside the normal way. We had it written on the sheet that was available at the clinic, so I just advanced him higher to a VOR ×2. Some of our other patients, we would only get to a VOR ×1. And then have a discharge, just because we were real busy with the vestibular treatments all the time. And if they needed further balance treatment, we would refer them to another PT in the clinic to continue on with more of the balance therapy. As for treating differently, I would have also looked further into balance and other vestibular exercises, such as like multiple moving background exercises, using how we're taught in class, like using a picnic blanket or other activities too, just to continue working the vestibular system. In that regard, also maybe something like the DBA exercises too, just to work on. He has to read while he's driving as well, so getting some different functional activity as well for that regard. As for reassessing central signs, I should have, especially having a previous diagnosis of a TIA, I should have gone further into this. we've learned in school, and I'll go into it a little bit as well too. We learned about hints, just to kind of cover the basics. I did not do head and pulse testing because of his limitations with neck rotation. And as far as gaze focus stagnance and test askew, I would have gone further into that if he did not respond well to the positional testing. Also, I would have given further cervical exercises, and after this patient, we did actually instill checking blood pressure for all of our patients as well, instead of just checking sporadically if they presented with deficiencies in that area. So as for evidence-based practice, rationale, here's some of the research that it says to, although multiple canal BPPV is rare, posterior and horizontal canal involvement on the same side is a more common type of multiple canal BPPV. Treating the posterior canal prior to horizontal canal with successive treatments is also documented in a lot of research. Reason being, anatomically speaking, if there were going to be any crystals that would go from one canal into another, posterior does drop into the horizontal canal sometimes, especially if the patient does not keep their head tucked a little bit during the epi. If they bring their head up quick, it could drop a little bit. Also, the 24-hour precautions is a very controversial topic right now in the vestibular world. 2017 clinical practice guidelines say that you don't need to do restrictions, but for the other two parts of evidence-based practice are patient values and clinical experience. And for the patients that we saw, they all responded better. Those who followed the restrictions did a lot better than the ones who didn't. You can almost pick them out when they came back into the clinic. As for DGI score, minimal detectable change is 4 points. I only had 3 points. I also only did half the test, so take it or leave it as you want. And there's a lot of research being done now too about vertigo with anxiety mimicking diagnosis of a TIA. And so the fact that he presented with those symptoms so quickly and then had a MRI that was clear helped also back possibly a little bit more. That's why I would have wanted to check more of his central signs as well. Playing devil's advocate though, MRI is often false negative in the first 48 hours after onset of symptoms. So that would just need further follow-up in the future too. So before I talked about hints as well, so we won't recover that now, but the patient did report complete return to prior level of function after vestibular treatment. And so that just demonstrates the importance of proper diagnosis in both the acute and outpatient settings. Like I said, just listening to the patient values, that definitely helped quite a bit with getting this patient back to work and getting him safe as a bus driver again. At this point, questions? Yes, ma'am.
So I will go back to the musculoskeletal issues with the C-spine. Did you do any joint assessment?
We did. I did a C1, C2, just a joint mobility, just general. So just trying to see if he had any PA movement as well. That was outside of the normal range. He was a little more firm, and he also had that suboccipital tension too. So I was kind of relating the two together with that.
Yeah, I just wondered, since he's a bus driver, would any joint mobilization, adding that on as well to try and get that full range of
the fact that he didn't have any pain at the end and he was still at 70 degrees, it's still within functional limits, but for him as a bus driver, yeah, definitely giving him further exercises to increase his rotational range would have been beneficial.
Were you able to reproduce his headache pain at all with any?
No, he did not ever have that lightning bolt ice pick headache, which I was grateful for because like Dr. Austin had said, like if you see that, like kick him out immediately. So I kept asking him like every time I do something too, hey, you got a headache? Like I don't want to, like, don't have it, but no, nothing brought up that headache.
Do you think some of the stability exercises help with that, or?
I would have liked to have given more cervical stability exercises too. One of the ones we gave a lot was the milkmaid. So like for just that cervical stability overall. But you know, hindsight 2020, I wish I could have had more time with him. He was also always in a big rush to get in and out of the clinic, as is everybody else. So trying to give a little bit of time for him to cooperate was it was difficult for that too.
As far as cervical, does he take range of motion or just end range of motion?
He just stated he had more like static discomfort. It wasn't like pain with range of motion. He was just saying like that first day when he came, he was like, oh, my neck's tight, it's uncomfortable sitting here right now. And so that was one of the reasons, just to get the neck to loosen up a little bit with heat knee stim. And that was just something we had seen a lot in the clinic as well too, that a lot of our patients, they'd come in with this super tight neck, and reason being, hey, if you're suffering from vertigo, pretty severe vertigo, everybody does the same thing. You're gonna tighten your neck up a little bit too. But that was the one thing, checking for cervicogenic dizziness as well. That's where I kept asking, hey, like with range of motion if you had dizziness as well too.
So my follow-up question is that, is this range of motion, I believe, was like 68 degrees?
Yeah, 68 and 70.
So your thoughts as to we should be doing an impulse test because of his cervical limitations. Or with an impulse test, you don't necessarily have to go like in that full 68 to 70. So
Right.
In retrospect, I think that's something potentially done with them, or what was the rationale?
Yes, for any patient that did have any type of cervical limitations, there was just kind of the clinic mentality to kind of axe it from the get-go unless we needed it further down the line. There's just, I think there had been some bad results in the past with people who had some cervical limitation, who might have been able to do it slowly, but then when you could do that quick jerk, they weren't a big fan of the clinician after that. So that was, I would just follow along with the clinical instructor's mentality on it too.
I don't know if it's right or wrong, but I don't want to have an impression that you couldn't necessarily.
Sure. Yeah, absolutely. Good. Yes, ma'am.
Did she